All right, so this is going to be a long one. We're going to have understanding ventricular depolarization and repolarization abnormalities, QRS, ST, and we're going to start with T wave abnormalities. So we have hyperacute symmetric T waves. This can appear within minutes of an event followed by T wave inversions. This is usually greater than 1 millimeter in 2 contiguous leads. Normal T wave inversion is usually seen in AVR, V1, or lead 3. Isolated T wave inversion in AVL is considered a mid-LED lesion or inferior MI. Some differential diagnosis for T wave inversions. Myocardial ischemia is the first thing to think about, prior MI as well. But we can also think about acute PE, especially with RV strain, with S1QT, Q3T3 pattern in RBBB. And we can also see T wave inversions in intracranial pathology. These are called cerebral T waves. Usually these are asymmetric, but we can also see this in a variety of different pathologies: myocarditis, pericarditis, abundant branch blocks, the digoxin effect, and also normal variants as well. So it's always important to compare to prior EKGs. The Winters T waves are found in 2% of STEMIs. They're tall, symmetric T waves greater than 1 millimeter ST depression at the J point. And this suggests acute LAD occlusion. Next, ST segment changes. We have ST depression. This indicates a subendocardial injury. The way I like to think about it is ST elevation is epicardial. From the epicardial to endo, this is subendocardial, greater than 0.5 millimeter below baseline, 80 millisecond after the J point in 2 contiguous leads. So that's the definition of ST depression. Usually seen downsloping or horizontal. ST depression, this is more ominous. This is not localized to a specific territory, but if you have ST depression V1 to the V3, it's always important to check posterior leads in order if there is an underlying posterior MI. ST elevations suggest transmural ischemia and is defined as greater than or equal to 1 millimeter in most leads except V2, V3. These leads has to be greater than or equal to 2 millimeters in men and greater than or equal to 1.5 millimeter in women. Okay, next up we have Q wave abnormalities. Pathologic Q wave suggests scar tissue, likely from prior MI, and these are deep Q waves that have to be greater than 1 millimeter and at least 25% of QRS complex height and greater than 40 millisecond in duration. And sometimes you can see physiologic septal Q waves, but these are small and normal and seen usually in V5, V6, lead 1, and AVL.